chance it. Where's the mouse? There it is. Okay. And so there are some there are some risks, obviously we've talked about slightly, but there are some benefits to oral contraceptive hormonal-based therapy. And so it's been shown in terms of ovarian cancer specifically that the number of lifetime ovulations contributes to the greater risk of developing ovarian cancer, because they think ovarian cancer is an inflammatory component in terms of this persistent rupturing of the epithelium. And so obviously if you've been pregnant multiple times, if you have multiple children, or if you're on birth control, you're severely reducing the number of ovulations. And so that kind of goes along with this inflammatory hypothesis here that reducing ovulations, or the process of ovulation, dramatically reduces the risk of developing something like ovarian cancer, endometrial cancer, ectopic pregnancy, as well as pelvic inflammatory disease. Of course, having these hormonal tablets on board is going to severely restrict some of the menstrual disorders that are kind of brought on by possibly aberrant hormonal production. And so, uterine bleeding, dysmenorrhea, ovarian cyst, even acne. A lot of these are going to be severely reduced by giving some of these oral contraceptive tablets. And other inflammatory conditions, possibly colorectal cancer and RA, are also slightly benefited by placing patients on oral contraceptives. Okay, so there are some risks and there also are some benefits as well. Okay, and so so that kind of leads us into what are the other uses to give these pills besides contraception, and those are listed here. And so honestly, this is kind of going back to the 1960s when these drugs first got approval. We were actually using them to treat endometriosis, polycystic ovarian syndrome. I don't know if they knew exactly what that was back then, but they were treating it. PMS. Very heavy monthly bleeding patterns that are discovered in anemic patients, and so forth. And so, a lot of these clinical uses were actually the first uses for these drugs before they got approval for contraception, as kind of society's perception of these things changed within that 9 to 10 year period. There are some adverse effects to these drugs: nausea, edema, specifically with estrogen, breakthrough bleeding. The blood proteins can be kind of thrown off, particularly the thyroid and adrenal proteins. Headache, we had talked about, and then no withdrawal bleeding. So the patient might actually think they're pregnant. They're not. They just have a very, very, very light period. Some of the moderate adverse effects include weight gain. Some patients talk about altered skin pigmentation, hirsutism, vaginal infections, amenorrhea. These are kind of more moderate adverse effects. And then, of course, severe adverse effects include cardiac infarct, DVT, PA, cerebrovascular diseases, gallbladder problems, depression, and then cancer. So even though we're reducing the risk of endometrial and ovarian cancer, we don't really know what these drugs do in terms of cervical cancer. And then, of course, with breast cancer, if the patient is an ER-positive tumor, or if they have the BRCA mutation, these drugs could actually contribute to cancer exacerbation and development. And so what reduces the efficacy of these drugs is really kind of a missed dose. So if the patient forgets to take one of their tablets, that dramatically reduces efficacy. If they forget to start on the proper day, that'll reduce the efficacy. Changes in absorption, diarrhea, vomiting, especially diarrhea and vomiting shortly after taking the tablet, obviously, because it wouldn't absorb. Then there are tons of drug-drug interactions, many of which are listed here. And so all of those would dramatically reduce the efficacy. There's a classic example of drug-drug interactions in the literature and their effect on birth control, because it's an important thing to know and to consolidate before you initiate one of these new drugs, especially for younger women of childbearing age. It's a good idea to take a good history and find out if they're using birth control. And so there's other ways to get these tablets, these chemicals in. There's patches. This is great for these, either the non-compliant or more likely the forgetful patient, excuse me, who just, for whatever reason, can't remember to take a pill. There are vaginal rings that would secrete some of these hormones. What's nice here is that you would avoid the first pass effect, and it's a monthly administration. There are injectable progestins. There's depot formulations, and then there's some subdermal implants as well. And so there's other ways to get these hormones into the body without taking a tablet. Of course, we can't talk about contraception without mentioning, excuse me, intrauterine devices. These can be hormonal or non-hormonal. So the non-hormonal ones are typically metal, and within that they're typically copper. Typically, they're contraindicated for women who are at a higher risk of developing or catching STDs, women who have a high risk for endocarditis, and women with a history of leiomyomas. And so basically, because the IUD is going to kind of alter the shape of the uterus, these leiomyomas can manifest themselves. So let's briefly talk about emergency contraception. So emergency contraception, sometimes called the morning after pill. There's also other formulations, Plan B, Next Choice, etc. And here we see the condom breaks or the diaphragm slips. Sometimes it's called mechanical failure, results in unprotected sex. So after intercourse, implantation of a fertilized egg takes about 5 days. And so that's kind of like our window of opportunity here. So some of the high-dose progestins, such as levonorgestrel, will interfere with that step of implantation of a newly fertilized embryo. And so Plan B, sometimes called or postcoital contraception. There's different formulations now. It used to be just one formulation, so the next couple slides talk about the different formulations that exist. Basically, they're looking at using levonorgestrel, LNG. So Plan B, also called One Step, is kind of a second-generation progestin. You can use it in the U.S. or you can obtain it in the U.S. without a prescription. It's a single 1.5 milligram dose, and it's best taken within 72 hours of unprotected intercourse. Kind of the next choice example is the newer formulation, and as far as I remember, no prescription is needed. And here we see 2 doses. Excuse me, 0.75 milligrams taken 12 hours apart. So there's 2 different formulations that exist. And so the ideal window of opportunity is really kind of, in terms of Plan B, to inhibit an unwanted pregnancy is this phase right here. And so, looking at like around day 3 to around day 10 or so. UPA or Ella, it's effective for up to 120 hours after unprotected sex. In the US, this one is needed with a prescription. However, in Canada, it's OTC. It's both a progestin receptor agonist or antagonist. It depends on the receptor subtype and the tissue distribution or expression. But it's 30 milligrams, and it's effective within 5 days of unprotected sex. And then that window of opportunity is a little bit wider. So it goes up to and including that LH surge by around day 14. This is a single dose, 1.5 milligram LNG or 30 milligram UPA. And here we're looking at In terms of how these drugs work mechanistically, we're looking at inhibition or postponing ovulation. Doesn't really prevent fertilization, it doesn't prevent implantation, and there's no effect on pregnancy if implantation's already occurred. This is in contrast maybe to mifepristone, also known as RU486. This is an anti-progestin, currently known as a progesterone receptor modulator. It also has the ability to block glucocorticoids as well, and it's an abortifacient, so it induces abortions. It terminates pregnancies less than 50 days in duration, and it's also given with prostaglandins within 48 hours to facilitate uterine relaxation for expulsion of the fetus. And so here's the mechanism of action during the luteal phase. Basically, it induces decidua breakdown, and that's through the inhibition of progesterone signaling. At this point, the blastocyst will detach. That's going to reduce HCG production. At this point, the corpus luteum is going to reduce the secretion of progesterone because of the lack of HCG that it's receiving. Less progesterone in the uterus is going to increase prostaglandin levels, and that'll soften the cervical tissue, which will aid in assisting the expulsion of the blastocyst. So that's the mechanism of how mifepristone works. There's also a mechanism during the follicular phase. It'll delay or prevent ovulation if it's taken early enough, and that mechanism probably goes into that feedback loop that comes from the hypothalamus and goes to the pituitary. Side effects: profuse vaginal bleeding. You're shedding a lot of potentially really thick uterine lining, and that's going to be demonstrated by a lot of blood loss. It's been used in other diseases. It's been used as a treatment for Cushing's disease, induced hyperglycemia, which is secondary to hypercortisol serum. It's been used for endometriosis. It's been used as a treatment for breast cancer and leiomyomas. And of course, the window of opportunity for mifepristone is the widest, right? So you can use RU486 pretty much any time to induce an abortion. And so this is basically kind of an overview of oral and emergency contraception, and we're really looking at two drugs, estrogen and progesterone.